Good evening to all the faculty members and the delegates present here. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on thyroid disorders in pregnancy.
There is some background noise.
Yeah. Organized by Amox Medical Disorders Committee with Ratlam and Reva societies. So let me introduce the convener of today's webinar, Dr. Dolly Mehra. Ma'am is the consultant obstetrician and gynecologist at Mehra Nursing Home, Ratlam. And ma'am has been the president of Ratlam OBGYN Society from 2014 to 19 and organizing chairperson of...
Saiti, that's enough. That's enough, Saiti. Thank you so much.
Okay, thank you, ma'am.
That's enough. Good evening, all my seniors, respected juniors, my respected seniors, and all the delegates. So wish you all a very happy Diwali, and after all the celebrations, let's get back to serious academics. I welcome today's chief guest, Dr. Rajendra Singh Pardesi, President AMOX, Dr. Sujata Dalvi, Secretary AMOX, our guest of honor today, Dr. Lakshmi Shrikhande, ICOG Chairperson, Dr. Kavita N. Singh, Professor and HOD at Jabalpur Medical College. So today we are here to discuss most very important topic of thyroid disorders in pregnancy. So before we start, let's get together, join hands and for lamp lighting to worship Ma Saraswati, goddesses of knowledge.
आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम्
So to start with, I have the privilege to introduce Dr. Sneha Bhuria. Dr. Sneha ma'am, as we all know, she's a very, very hardworking Foxy member. She has been awarded many times, but before that, she was the Breast Committee Chairperson 2019-2020. She's Governing Council member of ICOG 2021-2022. She's AMOX Medical Disorder Chairperson. She is in the CEPHOG working group. She is founder chairperson of ISOPAR with her, and she's peer reviewer for Jogi. She has many awards to her credit, like International MS Signature Award, Dr. S.N. Malhotra Individual National Award for Outstanding Work in Rural Obstetrics, Distinguished Durusha Madam Community Service Award, Dr. Anandibai Joshi State Award by the Government of Maharashtra, and she has been a very active member of Foxy. She has 30 chapters and articles in national publication. I welcome Madam for
Thank you, Dr. Dolly. Thank you so much. So, a very good evening, one and all. At the outset, my respect and regards to AMOX President Dr. Rajendra Singh Pardesi, Madam Sujata Dalvi, who could not join because she's in US and it's around 4:35 a.m. there, but maybe she will join soon. Immediate past President of AMOX, Dr. Nandita Palshetkar, and President-elect Dr. Kiran Turtikoti. Guest for today's program, Dr. Lakshmi Shrikhande, Madam, as you know, the ICOG chairperson, very active, vibrant personality who has taken ICOG to the next level, and Professor Kavita Singh, as you just heard, the professor and head of Department of Jabalpur Medical College and state president of AMPOX. Special guest, Madam Leela Joshi, who always be there to bless all of us. I welcome all of you as a committee chairperson from AMOX Medical Disorders Committee. At the outset, let me thank Dr. Pardesi and the entire team of AMOX for the opportunity for being with all of you and discuss this important subject. I thank Dr. Sunita Wadhwani, Dr. Aditi Rathore, Dr. Dolly and Team Ratlam, and Dr. Padma Shukla and Dr. Rekha Singhal and Team Reva for having us here. We are happy that we could reduce the maternal mortality rate to less than 100, and congratulations to all of us, all of our organizations for sharing the knowledge and experience. And of course, we are tackling these medical disorders, which are very, very important as far as the complications during pregnancy is concerned, which lead to the maternal serious morbidity or mortality. So we discuss anemia, hypertensive disorders of pregnancy, hyperglycemia in pregnancy, heart disease, liver disorders, thyroid disorders during pregnancy. I'm sure this topic is the least discussed, but most important. And I'm happy that all of you selected this topic. I welcome my dear friend, Dr. Vidya Thobe, who is the president of Karnataka State Obsgyne Association, and she will speak on hypothyroidism during pregnancy. And I, Dr. Sneha, will moderate the panel discussion on thyroid disorders during pregnancy. I also welcome Dr. Padma, Dr. Neha, Ayushi, Kalpana, Sonu, Dr. Sonal, Anjum, Sheetal. I'm sure all of you will take this discussion to the next level and give a crystal clear, crisp messages, take-home messages. So with this, I invite Dr. Sunita to introduce and invite Dr. Pardesi sir first, and Sujata ma'am if she has joined for their words of wisdom. So over to you, Dr. Sunita. Please unmute yourself.
Unmute yourself.
A very good evening to everybody, and a happy Diwali and a prosperous new year to everybody. And thank you very much, all of you, for being here on the vacation time of Diwali. It is my privilege to be introducing a very important part from AMOX, Dr. Rajendra Pardesi sir. Sir is President AMOX 2022 to 2024. Sir was Vice President AMOX 2018-22. Sir was VP Foxy 2019-20. He has 28 paper presentations, 21 in nation and 7 in international. Sir has 7 times Best Paper Awardee in Foxy AICOG conferences. He was facilitated in he was faculty in AOCOG 2011 at Taipei and AOCOG 2013 at Bangkok. Sir was faculty at FIGO 2006, Kuala Lumpur, and FIGO 2012 at Rome. Sir was chairperson of Food and Drug Committee, Foxy 2012 to 2014, and was awarded Dr. Hansutia Best Committee Award, Foxy. Welcome, sir. Thank you very much for being here.
Good evening, everybody. Respected Dr. Sujata Dalvi, Dr. Lakshmi Srikhande, our ever active, ever smiling chairman of ICOG, Dr. Kavita Singh, Dr. Vidya Thobi, President Kasoga, Dr. Sneha Bhuyar, our ever active chairperson of AMOGS Disorder Committee, Medical Disorder Committee, Dr. Dolly Mehra, Dr. Leela Joshi, and friends. I am really happy for this joint program of AMOGS with Ratlam and Reva Ubijoy Society. Hence, to congratulate Dr. Sneha Bhuyar, Dr. Sunita Wadhwani, Dr. Aditi Rathore, Dr. Padma Shukla, Dr. Rekha Singhal for organizing such a webinar on practical topic of hypothyroidism, which is useful in our day-to-day practice. As you all know, we'll be knowing that women with hypothyroidism have decreased fertility. Even if they conceive, the risk of abortion is increased, and the risk of gestational hypertension, anemia, abortion, placenta, and PPH is increased. And I think the complications are greater than a woman with overt rather than subclinical hypothyroidism. Of course, this will all be discussed in this webinar with eminent faculties like Dr. Vidya Thubbi, Dr. Sneha Bhuyar, and other chairpersons, Dr. Neha Saraf, Dr. Ayushi, Dr. Sonu Bathram, Dr. Anjum Sayyad, Dr. Sheetal Patel, Dr. Sonal Agarwal, Dr. Kalpana Yadav, Dr. Binu Kushwaha. I wish every success to Dr. Sneha Bhuyar and Dr. Vidya Thubbi for their future endeavor as Vice President Foxy in coming elections. I don't want to be in between you and excellent scientific content. I'm wishing every success to this webinar. Thank you. Thank you so much for inviting me. Jai Hind, Jai Maharashtra.
Thank you so much, sir, for the blessings. I now request Dr. Sneha to introduce our guest of honor. Today, Dr. Lakshmi Shrikhande, Chairperson of ICOG, Dr. Kavita Singh, who is my own AMPOX president and a very passionate person for dealing with CA in cancers, prevention of cancers in women. Over to you, Dr. Sneha.
Yeah, thank you so much, Dr. Dolly. And indeed, it's a pride and privilege to introduce Dr. Lakshmi Shikande, who is a very dear friend of mine and a pride of our region, I would say, Vidarbha. The first lady ICOG chairperson from our side, rather a first ICOG chairperson from our region, I would say, and a very vibrant personality. She also was a winner of the Merudara Hansotia Award for her best committee, and she was a chairperson for HIV/AIDS committee Foxy, and she was a senior vice president of Foxy. And as ICOG chairperson, I have already said that you are enjoying academic based almost day. So she has taken ICOG to the next level, and I'm sure she is, very, very deserving person to the highest post of this organization, I'm sure. And all the very best to you, Dr. Lakshmi. And yes, definitely we are eager to listen to your precious words. Over to you.
Thank you. Thank you so much, Sneha. And very good evening to one and all. And I hope you all must have enjoyed these Diwali festivities. And now AMOX wants you all to be back to the academics. And must say that our AMOX president, Dr. Rajendra Singh Pardesi, is doing a fantastic job as AMOX president. So wonderful. Please keep doing your good academic work. And you are doing a wonderful job connecting people and spreading the knowledge. And what to say about Sneha? I know her since last 3 decades, the most hardworking, sincere, dedicated, Foxian, whatever responsibility you give it to her, and you can just chill and relax. And Sneha will do the everything possible to make that event a grand success. And I'm so happy, Sneha, that now as the chairperson of Medical Disorders Committee, you have come out with this webinar series, and which is the need of the hour. Whatever we can do, as you already said, ki maternal mortality has been reduced, but we can reduce it to still lower level. And this initiative will work wonders as far as reducing the maternal mortality, not only mortality, even maternal morbidity. So keep doing your good work. Keep connecting people, and I'm so happy with the 3 state presidents, Dr. Rajendra Singh Pardesi, Maharashtra State President, Vidya Thobi, Karnataka State President, and Kavita Singh, dear friend, from MP State President. So happy to be in the company of 3 state presidents along with my dear friend, where is Dolly? Dolly. Yes, who are the past president. Dolly, I'm so happy to be here with you all. And I'm sure the choice of topic, the choice of faculties you have done, Dolly, is really commendable. And I'm sure all the faculties will be giving a clear-cut take-home message to the audience. So keep learning. And Sneha, wish you all the very best, not only for this webinar series, but for all your future endeavors. And thank you so much for inviting me here. And I am handing over back to you for further proceedings.
Thank you so much, Dr. Lakshmi, for that very encouraging message. And yes, again, it's a pride and privilege to introduce Madam Kavita Singh, as she is a professor and head of Department of Obs-Gynae, NSCB Medical College, Jabalpur, and she's, of course, the president of AMPOX, as we just heard. She is the WHO Master Trainer for Colposcopy and Gynec Oncosurgeon, the hot topic, I would say, need of the hour, as we have been always talking about. It's really very, very creditable, madam, that you are training so many obstetrician gynecologists on this aspect, and definitely it will be very useful for reducing the mortality which is associated with the gynec cancers. Madam has so many awards and accolades to her credits, and of course, so many publications also. But without wasting much time, I would hand over to you, Madam, for your precious words. Dr. Kavita Singh, over to you.
Yeah. Good evening, Dr. Sneha, Dr. Lakshmi, Dr. Pardesi, Dr. Dolly, Dr. Wadhwani. I'm really thankful to all of you for inviting me for this prestigious CME on medical disorders. As far as Lakshmi was saying, I am Lakshmi. I have yet to take the charge of president of MPOX.
You are elect.
It has not been handed over. So I'm just the time. But anyways, yes, as a teacher, I'm more happy to be introduced like what Dolly said and what Dr. Sneha said, a passionate teacher and a person who is into grassroots work and into teaching and training to youngsters. So, as this is an academic program, my best wishes to Dr. Sneha. And I think that's all. I want the presentations to start. So, my best wishes to all of you. Thank you so much for inviting. Thank you.
Thank you so much, madam.
Thank you so much. And I request Madam Leela Doshi, actually, Madam was facing some problem for her video and audio. So I just hope, Saiti, have you sorted out the problems? So if at all Madam joins later in this program, we will have her blessings. And definitely, thank you, all the dignitaries, respected Dr. Pardesi, sir. Madam Sujata Darvi could not join, I said, but yes, thank you so much to her also. Madam Kavita Singh and Madam Lakshmi Shrikhande, all the dignitaries here, thank you for sparing your valuable time and blessing us and gracing the occasion. Thank you so much. With this, I hand over the forum to you, Dr. Dolly, for the academic session. Thank you so much.
Thank you so much. To start with the session 1 on hyperthyroidism during pregnancy by Dr. Vidya Thobi, who is president of Kasoga. I invite chairperson, my own, Dr. Sunita Wadhwani, president of my own society, Ratlam Obs and Gynae Society. She is an ABH accessor. She is MBA in hospital and healthcare management, and she has special interest in critical care obstetrics. She is also lead assessor and master trainer for Manata by Foxy. I also invite the second chairperson, Dr. Binu Kushwaha, who is professor in the Department of OBG SSMC Riva Medical College. She is recipient of 5 gold medals and Best Student Award, and she has also been awarded by the International Journal of Obs and Gynae, FIGO Journal, for her original work on medical abortions. She is recipient of West Zone Kamini Rao Orator in 2015. She is recipient of Foxy Korean Award and first runner-up in the senior category. So, welcome Dr. Binu Kushwaha and Dr. Sunita Wadhwani. Now, over to Dr. Sunita Wadhwani to introduce our speaker, Dr. Vidya Thobi, madam.
Good evening again. It is a privilege to be introducing Dr. Vidya Thobi, ma'am. She's president KSOGA, that is Karnataka Society of Obs and Gynae 2324, professor and head of the Department of Obs Gynae, Al-Amin Medical College, Vidyapur. She's chairperson, Food, Drug and Medico-Surgical Equipment Committee, Foxy, 2018 to 2020. She has won Best Committee Foxy Award, Dr. Mehru Dara Hansotia, 2020. She's ICOG Governing Council member 2021-23, Foxy Chairperson awarded in 2019, National Corresponding Editor to Jogi. She has organizing chairperson of KSOGA 2016. She is president Bijapur Obs Gynae Society 2009. Secretary Bijapur Obs Gynae Society 2007. She has publications of various books and contributed to Foxy. She has focus and speak many national and international conferences. She has many papers in national and international conferences to her credit. She has organized various CMEs, workshops, and awareness programs. She was an advisory faculty of Board Rajiv Gandhi University of Health Sciences, and she has been postgraduate and undergraduate teacher for last 30 years. Welcome, ma'am, and thank you very much for delivering us this lecture. This is a very important lecture for us, ma'am, because hypothyroidism we always hear, and hyperthyroidism is something we really don't hear it that often.
Thank you, Dr. Sunita, for those nice words. And dear chairpersons, I am really
ma'am, your voice is not
glad to be amongst you, our queen of amongst medical disorders committee, that is Sneha Bhuyar, who has put her heart, everything in this webinar. She organizes various webinars with purpose, and I hope that this webinar.
Ma'am, your connection is not that clear.
Yeah, I think Dr. Vidya, your
serve that
network
purpose.
is very poor.
I thank Maharashtra Amox President. Poor. Okay. I'm not audible, Sneha?
No, ma'am. It's not very clear.
Ma'am, your voice is breaking.
So can I make my video off and speak then?
Yes. I think you can try that.
I will. Okay, I'm sharing my screen. And,
yes, ma'am. Please make it full screen, ma'am.
Yeah. I will do that.
Hello, Vidya.
Yes. I think my screen is visible now.
Yes, ma'am.
Yes. You can put off your video so that, at least the bandwidth will be good.
I think so. Am I audible now?
Yes, ma'am. It's
Hello?
clear. It's clear, ma'am.
Yeah. So thank you again, Amox, as well as Reva and Ratlam societies. I just want that Karnataka OBGYN society is very thankful that I am amongst all the stalwarts of
Vidya, you're not very...
Dr. Kavita Singh, as well as this.
Ma'am, your voice is breaking.
And Reva societies. Actually, I'm very close to Dolly also. So thank you very much. And let us know something about the thyroid physiology before we are talking about something about hyperthyroidism. So anyway, we are discussing some of the cases in the panel discussion. But before that, as was told, it was hypothyroidism are often we discuss, but hyperthyroidism the topic is rarely discussed. So thyroid disease is the second most common endocrine disorder after diabetes in pregnancy. And thyroid disease poses a substantial challenge on the physiology of pregnant women. And it has got a significant maternal as well as fetal implication, though the incidence is less. Now, what about the thyroid gland and about its physiology? So there is a profound impact of thyroid gland, its function during pregnancy. The gland increases 10% in size during pregnancy in iodine replete countries and by 20 to 40% in areas of iodine deficiency. So production of T4 and T3 increases by 50% along with the 50% increase in daily iodine requirement. So these are the physiological changes which may result in hypothyroidism in later stage of pregnancy in iodine deficient women who were euthyroid in first trimester. So the incidence of hypothyroidism is much more than hyperthyroidism. And just we should know about the role of thyroid in pregnancy, that is brain, nervous system, psyche. It has got a profound impact on the growth and development, energy metabolism and oxygen consumption, protein, lipid and carbohydrate metabolism, cardiovascular system, bone metabolism, muscle function, fertility and pregnancy. So we all know that how thyroid has got intricate impact on all these various functions. We all know the thyroid physiology. So there is an increased estrogen in pregnancy, which increases 2 to 3-fold of thyroid binding globulin, which decreases free thyroxine T3 and T4. And the similar structure of SCG and TSH. SCG stimulates the release of T3, T4, and there is a transient decrease of TSH in
Dr. Vidya, ma'am?
I think Vidya, your network is very, very poor. If you can change the network, that will be good.
I think I'll change my. I'll come out and just see in another room. Hello.
Yes, ma'am.
Now I am audible.
Yeah.
Yes, much clearer.
Yes, I changed my location. Yes. Okay. So about the iodine status and the nutrition in pregnancy, because nutrition is very close to my heart. So iodine requirements are increased during pregnancy. There is increased thyroid hormone production, increased excretion of iodine by kidneys, and also the fetal iodine requirements. Iodine is also secreted in breast milk, and lactating women also need increased iodine. So maternal iodine deficiency lead to, if it is severe, we all know it causes cretinism, mutism, motor rigidity. And if it is mild to moderate, it causes ADHD and impaired cognition. So this iodine content in our salt or whatever the food is very, very important. And WHO recommends 250 microgram per day iodine for pregnant and lactating women. So what about the thyroid autoantibodies and pregnancy? We always discuss. So there are various antibodies like thyroperoxidase antibodies, anti-thyroglobulin antibodies, and in women with thyroid antibodies, hypothyroidism may occur due to stress of pregnancy as well. So such women should have TSH measurement every 4 weeks through mid-pregnancy. So there are various screening guidelines and screening for thyroid dysfunction during pregnancy. And some people, they advocate only in the high-risk pregnancies and universal. Now everybody, FIGO and everybody, and even our Indian Thyroid Association and FOXY, they advocate the universal thyroid screening. So this is what they say, that you have to screen all pregnant women at first visit for abnormal TSH. Now, the TSH serum, TSH is the principal determinant of maternal thyroid status, and it is a guide to treatment, decisions, and goals. So, trimester-specific TSH range in pregnancy, I just want to touch upon, and that we all know that in the first, second, and third trimester, what are the levels. Now, what about the downward shift of the TSH reference range during pregnancy? So reduction in both the lower, which is decreased by about 0.1 to 0.2 milliunits per liter, and the upper limit of maternal TSH, which is decreased by about 0.5 to 1 milliunit per liter, which is relative to the typical non-pregnant TSH reference range. So largest decrease occurs in first trimester, we all know, because of the elevated levels of serum HCG directly stimulating the TSH receptor. So in the first trimester, we find that the TSH levels are decreased. And in multiple pregnancy, hereditary mole, there is a greater downward shift of this TSH. So whenever we are reading the TSH levels, we have to take a note of this. So these are the various trimester specific TSH range, reference range. We know in non-pregnant about 0.4 to 4.5, and in first trimester 0.1 to 2.5, in second trimester 0.2 to 3, and in third trimester it is 0.3 to 3. So these are the various ranges. What are the errors in the diagnosis if not followed? So using non-pregnant reference ranges, hypothyroid woman could be misclassified during pregnancy as being euthyroid. TSH is more than 2.5 but less than 4. So various reference ranges we have to consider. Now euthyroid pregnant woman could be classified as being hyperthyroid. TSH levels are very low, that is less than 0.4, but more than 0.1. So you have to see the reference range in which trimester you are doing that. Now, what about the hyperthyroidism in pregnancy? The incidence is 2 of 1,000 pregnancies, that is overt hyperthyroidism. 1.7% of the pregnancies we get mild or subclinical hyperthyroidism even. The etiology of hyperthyroidism in pregnancy, most common disease is the Graves' disease, 85 to 90% of all the cases. Toxic multinodular goiter, toxic adenoma, TSH-dependent thyrotoxicosis, iodine-induced hyperthyroidism, and HCG-associated transient thyrotoxicosis. That is what we call as gestational thyrotoxicosis. Now, what are the various types? Now, subclinical hyperthyroidism, there is suppressed TSH, normal free thyroid T4 and T3. Overt is suppressed TSH and elevated free T4 and T3. Gestational is detected only during pregnancy. So there are various overlapping symptoms which make it difficult to differentiate between hyperthyroidism from hyperdynamic state of pregnancy. So the patient complains of nervousness and irritability, palpitation and tachycardia. There is heat tolerance, increased sweating, pre-tibial myxedema, photophobia, eye irritation, diplopia, exophthalmos, weight loss and gain, tremors, sudden paralysis, fatigue and muscle weakness, frequent bowel movement, pedal edema, change in appetite, and thyroid enlargement depending on the cause. So these are the common symptoms, and some of them, they are overlapping with the pregnancy symptoms. Now, hyperthyroidism, ophthalmopathy, and pre-tibial myxedema, these are the common symptoms of hyperthyroidism. There is. Hello, am I audible?
Yes, ma'am, you are very much audible.
Yeah. Okay.
In between.
Okay. Yes. Difficult to diagnose due to similar clinical features as normal pregnancy. Thyroid peroxidase antibodies and thyroid hormone receptor antibodies are increased in most of the patients suffering from Graves' disease. Now, effect of pregnancy on Graves' disease, what happens is in the first trimester, aggravated symptoms of Graves' disease during first trimester due to increased HCG production. Thyrotoxicosis symptoms improve in second and third trimester of pregnancy. There is a reduction. This is because of reduction in TSH receptors stimulating antibody levels during pregnancy, which improves the symptoms of Graves' disease in second and third trimester. Postpartum symptoms, it is again increased due to sudden rise of the levels of TSH receptor stimulating antibodies. So this happens, these are the changes which happen in first trimester, second trimester, and third trimester, and postpartum. Now, effect of hyperthyroidism on pregnancy. Untreated severe hyperthyroidism causes number of menstrual disturbances in pre-pregnancy period, and pregnant thyroid women are at risk of miscarriage, abortions, stillbirths, intrauterine growth restriction, preterm labor, neonatal hyperthyroidism, perinatal mortality. Pregnant women with mild hyperthyroidism on treatment have good outcomes. That one should remember. Uncontrolled disease may result in thyroid crisis, that is thyroid storm, or heart failure during delivery. So these are the various dangerous complications of hyperthyroidism. Now, what about TSH receptor antibodies, which are present in a majority of patients of Graves' disease? And the measurement of this TRAb may also help to distinguish Graves' disease from gestational thyrotoxicosis in first trimester, as they are negative in gestational hyperthyroidism. So what happens is in severe hyperemesis, or if the patient has got high decadiform mole, they also have higher levels. So we have to differentiate. So in Graves' disease, we have that TSH receptor antibodies which are present. Because the Graves' disease tend to undergo immunological remission sometimes after the late second trimester, and the detection of TRAb may depend on the gestational age at that measurements. So diagnosis can be on clinical presentation, thyroid examination, thyroid function test, and thyroid antibody test. So overt hyperthyroidism during pregnancy may be referred as suppressed, that is less than 0.1 milliunits, or even undetectable less than 0.01 serum TSH value, and elevated thyroid hormone levels that exceed the normal range for the pregnancy. So that is how we can diagnose hyperthyroidism. A free thyroxine determination or calculation of free thyroxine index using thyroxine levels as a test for assessing TBG, such as resin uptake, are a routine test in most of the clinical laboratories. Now, almost every patient with these Graves' disease has elevated free T4 concentration or T4-1. So a suppressed TSH value in the presence of high free T4 and free T4I confirms the diagnosis of hyperthyroidism. In about 15% of the normal pregnant women, a low or suppressed serum TSH is present in first trimester of pregnancy. In some unusual situation, the serum free T4 may be in the upper limit of normal or maybe just slightly elevated, in which case determination of T3 and free T3 has to be confirmed for the diagnosis of hyperthyroidism. Thyroid peroxidase antibodies or thyroid antimicrosomal antibodies, markers of thyroid autoimmune disease, are elevated in the most of the patients of Graves' disease, and its determination is indicated in patients in whom etiology of hyperthyroidism is in doubt. So these antibody detections is very important to diagnose hyperthyroidism, that is Graves' disease. No, so this is just a pictorial. You can remember that when there is a serum TSH is depressed, there is elevated free T4 and free T3, then just check the TSH receptor antibodies for diagnosis of hyperthyroidism. So these are the various antibodies which can be, you can check, that is thyroid peroxidase antibodies, thyroid antimicrosomal antibodies, TSH receptor antibodies, and these are to be measured in first trimester itself, so that you can differentiate between gestational thyrotoxicosis and Graves' disease. Now, what about the preconceptional counseling? So what are the clinical situation? When hyperthyroidism is under treatment, potential side effects of anti-thyroid drugs on the fetus should be discussed. Even if it is, patient has to think of, she has to wait for 6 months after radio ablation if she has taken treatment. She should be euthyroid at the time of conception. Previous ablation treatment for Graves' disease. The dose of thyroid replacement therapy needs to be increased soon after the conception. And in spite of euthyroidism, high maternal titers of for any antibodies, if they are present, fetus is always at risk. So even though the patient is euthyroid and there are high titers of antibodies, and if you detect fetal tachycardia, you have to suspect the fetus has developed thyrotoxicosis. So you have to treat it immediately. The previous treatment for thyroid carcinoma, then if she has taken treatment, you have to wait for 1 year after the completion of radioactive treatment before conception. Now, management goals are to normalize thyroid hormone levels, keeping free T4 in upper normal range, that is less than 0.85 to 1.9 nanogram per deciliter, and to treat bothersome adrenergic symptoms on hyperthyroidism. So this is a picture how various drugs they act, like thiamides. Then you can see the iodinated contrast media and beta blocker. Then thioamide, they act in the conversion of T4 to T3 is blocked here. And even you can see the other drugs. So here they act at various levels. For the conversions, they act at the level of the whatever the from the T3 T4 to T4 T3 free, the conversion is blocked. Then release also is blocked. So they act at the various levels. Now, these are the two major drugs which are always discussed, that is thionamides. So most commonly used is the propylthiouracil, and which I told us it inhibits the conversion of T4 to T3. It crosses placenta less readily. The dosage is 300 to 450 milligram in 3 divided dosages, that is from 100 to 150 milligram each. It is a category D drugs. It has got its own side effects like iatrogenic fetal hypothyroidism, transient leukopenia, that is 10%, granulocytosis, hepatotoxicity, and vasculitis. The improvement is seen in 3 to 4 weeks and full response occurs in 8 weeks. It is tapered as the pregnancy advances. The second drug which is used is metimazole, that is dosage is 5 to 20 milligram twice a day. It crosses placenta also more readily. It is also category D drugs, but it is never used in first trimester, remember, because it causes metimazole embryopathy, as all of us know. It causes esophageal atresia, choanal atresia, and even the most common complication is cutis aplasia. So dose should be monitored with 3 to 4 weekly free T4 and these antibodies levels. You have to monitor them, and improvement is seen in 3 to 4 weeks again, and full response you will get after 8 weeks only. It is tapered as the pregnancy progresses. The side effects are transient leukopenia, so that you have to always monitor about the total leukocyte count. 10%, granulocytosis 0.3 to 0.4%, hepatotoxicity occurs in 0.1 to 0.2%, vasculitis also is a common complication and side effects. So this is a picture of cutis aplasia. Then propylthiouracil is always recommended during first trimester, as I told, because we always switch to methimazole or carbimazole beginning in the second trimester because of its own complications. This is just a comparison between propylthiouracil and methimazole. So propylthiouracil in first trimester, and as an alternative to propylthiouracil in the second trimester, we shift to methimazole. Most common complication is it is harmful to the hepatotoxicity is very common with propylthiouracil, and mothers with Graves' disease treated with propylthiouracil has risk of developing fetal hypothyroidism, because both of the drugs they cross. So both drugs they cause fetal hypothyroidism. The drug choice, it is most commonly used in North America, and this one is in Europe, South America, and Asia, they tell. But usually the first and second, why we shift to methimazole is the drug dosage is less. And the once a daily regime with methimazole and fewer major side effects may be considered more advantageous than propylthiouracil. So how to monitor? So initial, whatever the drug is we are giving, it depends on the severity of the disease, right? So then usually it is initiated 100 to 150 milligram 8th hourly, or you can give methimazole 20 milligram or carbimazole 15 milligram in divided dosage, which is guided by maternal T4 levels. And to avoid fetal hypothyroidism, the lowest dose possible to keep the maternal T4 level, the higher normal range should be used. So once you start the treatment, the patient should be monitored every 3 to 4 weeks during gestation, and the dose should be adjusted accordingly. Now, just I was talking about the monitoring. So apart from that, you have to monitor the maternal pulse, weight gain, thyroid size. If patient is having some nodule or something, you have to measure that. Ultrasound you can use. And measurement of total T4 and free T4 and TSH with the recommended therapeutic target. You have to keep a target of this one T4 at 12 to 18 microgram per deciliter. These are the given by laboratory and they are laboratory specific. So you have to just see the laboratory specific ranges and find out what is the range and in that area. The recommended range for TSH for the patient on ATD has been suggested to be 0.1 to 0.4 milli international unit per liter. Monitoring only by TSH is useful in late gestation when the disease is controlled. So you have to monitor mainly by free T4 and T3. After control of thyrotoxicosis, the dosage of that is propylthiouracil should be decreased to 50 milligram 4 times a day. If the patient remains clinically euthyroid, the propylthiouracil dosage could be decreased to 150 milligram per day, and then after 3 weeks 50 milligram twice a day. The pregnant woman with thyrotoxicosis should be maintained on low dosage as possible, preferably less than 100 milligram. And what about fetal thyrotoxicosis? Now, thyroid stimulating immunoglobulin levels, if they occur more than 35%, and TSH receptor binding inhibitory immunoglobulin levels more than 40%, if the patient has tachycardia, patient has goiter, you have to suspect about fetal thyrotoxicosis. And the second thing is, in 10% of the patient, which are exposed to drugs, they also develop because of crossing of these anti-thyroid drugs. They even cause hypothyroidism. So you have to monitor both. So clinical examination for the fetal growth, ultrasonography, the fetal heart rate, you have to monitor bradycardia if it occurs, and the growth parameters like fetal goiter, symmetrical paratracheal mass, or neck hyperextension or polyhydramnios. And in these patients, they advocate cordocentesis and the testing of various blood sampling. So routine blood sampling for thyroid indices is recommended if there is any previous ablation, radioactive iodine ablation, abnormal these various antibodies, and fetal growth restrictions, heart failure or goiter with or without tachycardia. So in these patients, they do cordocentesis and detect. What are the other drugs which are used in hyperthyroidism? One is beta-adrenergic blockers like propranolol. The mode of action is T4 to T3 conversion is inhibited. 20 to 40 milligram orally every 8 to 12 hours is recommended. What about surgery? Subtotal or total thyroidectomy is indicated when for any reason these drugs, they fail to control the hyperthyroid disease, or if the patient is requiring more than 300 milligram of propylthiouracil or 40 milligram per day methimazole, the appropriate time is second trimester. Ideally, the surgery requires previous pharmacological treatment to normalize the thyroid function. So after that, only the surgery is indicated. What about labor and delivery? The management option is you have patient on anti-thyroid medication well controlled, or in some patient, if patient has tachycardia and other complication, beta blockers, and most important is a supportive care. The fetal thyrotoxicosis, if it is suspected in labor, we have to treat it aggressively, the maternal thyrotoxicosis. And if the patient has got large goiter, sometimes the patient, there is a deflection, you have to consider the best route of delivery. It means you have to take this patient for elective cesarean to avoid dystocia. And you have to manage, the most important is a fetal airway. So neonatologist should be always there for attending of these cesarean deliveries. Now, this is just a simple chart for the diagnosis and management of hyperthyroidism in pregnancy. Any risk factor for thyroid disease, you have to do physical examination and serum TSH. If TSH is normal and normal free T4, just check up the gland, if it is a normal gland or a nodular gland. Normal gland, if the patient has got gestational thyrotoxicosis because of hyperemesis or other diseases, then you have to treat the supportive, you have to give the supportive care. If it is severe, you have to treat as Graves' disease. Patient has nodular gland, you have to do the thyroid ultrasonography. Then if the TSH is very low, less than 0.08 and elevated free T4, again you have to check whether it is a nodular gland or it is an enlarged non-tender gland or enlarged normal or tender or non-tender gland. So normal gland, nodular gland, you have to do thyroid ultrasonography. If there are multiple nodules, whether they are toxic, multi-nodular goiter, and then again you have to treat them either as supportive care or if it is severe, treat as a hyperthyroidism, Graves' disease. If there is a suspicious nodule more than 1 centimeter, you have to do fine needle aspiration. And if you are doing this fine needle aspiration with good histopathology, you have to just check whether it is a hyperfunctioning benign nodule or it is a thyroid cancer. If the nodule is again enlarged and normal or non-tender gland, if it is a thyroiditis, typically transient, if severe, then you have to treat it. Treat it with propranolol, corticosteroids, which protocol is all. Next slide, I will be discussing. Now, what about the Graves' disease? We have already discussed about first trimester, second trimester, the common drugs like propylthiouracil and metimazole. And you have to definitely monitor the fetal growth and fetal heart rate. Fetal ultrasound, if there is a small for gestational age, or if there are abnormal fetal heart rate, fetal growth restriction, and definitely you have to inform the pediatric care providers for the diagnosis. You have to check serum free T4 and various antibodies every 3 to 4 weeks, and you have to adjust antithyroid drugs to the lowest effective dose, and your goal is free T4 levels in the higher normal or mildly elevated. So you have to check all these things whenever you get a case of nodular goiter or nodules in the thyroid, as well as patient presents with clinical symptoms as well as laboratory findings with hyperthyroidism. Now, these are the various guidelines, recommendation following the treatment options for the patient suffering from Graves' disease. We have already discussed about the antithyroid drugs, surgical treatment, and I want to say something about radioactive iodine. It is contraindicated in pregnancy because of its potential to destroy even fetal thyroid. So we never give. And the next chart, which I have depicted, is the referral values for thyroid function test in pregnant Indian women. This is very important chart. I'm not going to go into the details of these various figures. You can just take a screenshot. It's, various guidelines are being given, and you can just refer whenever the case comes to you. Now, what are I just talked about the radioactive iodides. Now, iodides. Now, iodides are not at all indicated as a first-line therapy in pregnant women with Graves' disease. They may be used with caution in case of thyroidectomy. And this is about the gestational thyrotoxicosis, a severe form of nausea and vomiting when the etiology is not clear. It may be an evolutionary adaptation to prevent ingestion of noxious food, hyperemesis gravidarum, or benign and malignant conditions of hydatidiform mole, which is induced by the increased concentration of HCGs. And in these patients, sometimes surgery is indicated. But of course, we do suction evacuation, and many times we also find, I have seen one case of exophthalmos because of this hydatidiform mole. I just mentioned about the radioactive iodine therapy is contraindicated, and if it is given, you have to give the contraception for 3 months. There is no data or for or against termination of pregnancy in case of inadvertent exposure. Now, about the acute exacerbation of hyperthyroidism, which is life-threatening hypermetabolic state. And this is thyroid storm. And the classic features are fever, tachycardia with atrial fibrillation, nausea, vomiting, diarrhea, dehydration, agitation, delirium, and coma, and high output cardiac failure. Patient can come with jaundice and abdominal pain, and the precipitating factors can be preeclampsia, anemia, sepsis, and any surgery. And you can just see the check the lab values, and that can be T4 elevated, total leukocytic count elevated, transaminases elevated, and there can be hypercalcemia. Now, what are the ACOG guidelines for the management of thyroid storm or thyrotoxic heart failure in pregnancy? We have to inhibit thyroid release of T3 and T4. So propylthiouracil in higher dosage, that is 1000 milligram load by mouth, then 200 milligram by mouth every 6 hourly. Iodine administration 1 to 2 hours after propylthiouracil by sodium iodide, that is 500 to 1000 milligram IV every 8 hourly, or potassium iodide 5 drops by mouth every 8 hours, or glucose solution 10 drops by mouth every 8 hours, or lithium carbonate if the patient has an iodine anaphylactic history, 300 milligram by mouth every 6 hours. So further it blocks the peripheral conversion of T4 to T3. Dexamethasone steroids, you have to give 2 milligram IV every 6 hours for 4 dosage, or hydrocortisone 1000 milligram IV every 8 hours for 3 dosages. Propranolol, labetalol, esmolol, all have been used, all beta blockers used successfully to control tachycardia. However, caution must be exercised if using beta blockers in presence of heart failure. Supportive measures such as temperature control as needed, we have to give, means sponging and paracetamol can be given. So postpartum thyroiditis, postpartum rebound in thyroid autoimmunity can occur. There is a lymphocytic infiltration of the thyroid gland, and the likelihood of developing postpartum thyroiditis is related to the serum level of thyroid antibodies. Anti-TPO antibodies are present in 90% of women with postpartum thyroiditis, and the women with high antibody titers in early pregnancy have 40 to 50% chance of development of postpartum thyroiditis. So women with type 1 diabetes have significantly higher incidence ranging from 18 to 25% due to high prevalence of TPO antibodies. So there are two phases, hyperthyroid phase followed by hypothyroid phase. So autoimmune destruction of gland occurs, and there is a sudden release of stored hormone, and it can happen 1 to 4 months postpartum. It is self-limiting within 1 to 2 months, and it is an abrupt onset. The patient's complaints of fatigue, palpitation, sleep deprivation, nervousness, and irritability. Small painless goiter may be present. Antithyroid medications are not beneficial in these patients. Hypothyroid phase is again because of this immune destruction, loss of functioning of thyrocytes, 3 to 8 months postpartum, and usually occurs at 6 months. It lasts much longer, that is 4 to 6 months. Also, the patient complains of fatigue, weight gain, loss of concentration, and depression. I think whenever the patient comes with these complaints, we often overlook and we never check for any thyroid functions. So we must look into that. We have to find out whether it is just a postpartum thyroiditis. The patient identified with postpartum thyroiditis should be screened regularly, since 20 to 50% of the women will develop permanent hypothyroidism within 2 to 10 years. A TSH level should be done annually and prior to conception. And this is a simple algorithm of management of thyroid disease in pregnancy, which I have taken from the ACOG 2020 guidelines. It is very, very beneficial. I'll not go into the details of these three things. So I'll just read about something about hyperthyroidism. Whenever there is a decreased TSH, check for the free T4 and T3. If it is normal, it can be a subclinical hyperthyroidism, which does not need any treatment. There is no further evaluation or treatment is required. But if it is above normal range, you have to diagnose as overt hyperthyroidism. Consider the TRAB and all antibodies. Thyroid, this one, all microsomal, all antibodies if you have got facility, but most important is TRAB. Start anti-thyroid drugs, that is propylthiouracil, like 100 to 600 milligram divided into 3 dosages, or methimazole 5 to 30 milligram divided into 2 dosages. Again, you have to recheck free T4 and T3 and antibodies every 2 to 4 weeks and titrate to the goal of higher normal range. When the dosage stabilize, you can assess less frequently. So this is very good book. I have referred most of my slides to this. This is Thyroid Association as well as our own Foxy, and Foxy has also brought many guidelines. And this I have already mentioned that subclinical, as there is a subclinical hypothyroidism, there is subclinical hyperthyroidism as well, and it does not warrant any treatment where there is a normal free T4 and low serum TSH levels. In summary, thyroid disorders should be considered in pregnancy in patient at risk. So always check universal screening, and signs and symptoms may be misleading, so that there should be high index of suspicion. Thyroid test should be used and interpreted in the light of physiological changes during pregnancy. Judicious treatment is critical to assure the success in pregnancy outcome. Now, hyperthyroidism can have a negative impact in pregnancy. The diagnosis is very tricky and can be confused with hyperemesis gravidarum, gestational trophoblastic disease in pregnancy. So you have to critically test various antibodies. The guidelines suggest to use propylthiouracil in the first trimester and methimazole and carbimazole in the second and third trimester of pregnancy. So these are various recommendations which I have already discussed. So I will not go through this. And Foxy has brought under Dr. Rakhi Singh, who is this was I think released in the last year. So she has released this various booklet, Ready Reckoner on hypothyroidism and hyperthyroidism in pregnancy. And this is a national guidelines for the screening of hypothyroidism in pregnancy by our government of India. Thank you for the patient listening. I think I have done some justice to the hyperthyroidism, and definitely I would love to join the panel discussion. Thank you very much.
Thank you very much, ma'am. It was such a nice and mind-storming talk on hypothyroidism. I don't think Dr. Bindu is there, ma'am. Is she there?
No, I think Dr. Binu has some prior commitments or some emergency, I think, from family. And she has informed me that she will not be able to join. So you can make the comments. And if you have any questions, you can take it.
Thank you very much, ma'am. Such a nice and elaborate talk on hyperthyroidism. We have heard many talks related to hypothyroidism, but lately we have observed that hypothyroidism is being treated even in the village level also, because hypothyroidism, many people are aware of hypothyroidism. But when it comes to hyperthyroidism, even the physician fail to think what has to be done, what kind of treatment has to be done for this patient, and they are always stuck up. So very nicely you took up, you started with the physiology of the thyroid disorders in pregnancy and normal physiological changes of thyroid in pregnancy. Then you gradually went to hypothyroidism and switched over to hyperthyroidism, and very nicely elaborated. Now I don't think I need to send my patient even to physician to know how am I supposed to treat a patient of hyperthyroidism. Very nicely explained, and thank you very much, ma'am.
Thank you, Sneha, for inviting me, and thank you, Ratlam and Reva Societies. I'm really thankful to be amongst you. Thank you very much.
Thank you, Vidya, ma'am.
That was excellent. I think Dr. Dolly, we do have Madam Leela Joshi with us, and we welcome Madam. And yes, we request you, Madam, for your few words of blessings to you, Madam Leela Joshi. Please unmute yourself.
Thank you so much. At last I succeeded. If you once don't succeed, try again. This is the message.
Thank you very much.
Madam.
There was some gross fault, but somehow or another it got rectified.
Yes.
Maybe for the time being. Dr. Vidya, it was wonderful talk. I don't think that you have left any point for anybody else to ask or to question.
Thank you, Dr. Leela Joshi, madam. Thank you very much.
My blessings to all.
Thank you.
Today's chief guest, if is present, guest of honor, Dr. Lakshmi, Dr. Sujata, and you, Dr. Vidya, wonderful talk, and all my friends of Ratlam and Riva Society, and above all, Sneha, thank you so much for, I heard everything, though I was not visible, for making me a part of this wonderful webinar. I am very sure that after this thing, we'll become wiser for treating our patients. Thank you so much. My blessings to all. Thanks a lot. Thanks a lot. Yes. Thank you.
Thank you. Over to you, Sneha ma'am. Thank you, Leela Joshi ma'am. Over to you, Sneha ma'am, for the panel discussion, the most awaited panel discussion.
Yes, thank you so much. And yes, Vidya, that was a great talk, I would say, definitely. So all of us have become wiser in managing hyperthyroidism. I think we will utilize this opportunity to maybe put this cases of hyperthyroidism on a hold, or maybe we take it little later. But as Dr. Sunita has said, that we are very, well trained in management of hypothyroidism. So we start with the panel discussion, and I welcome all of you, Dr. Neha Saraf, Dr. Padma Shukla, Dr. Ayushi, Dr. Kalpana Yadav, Dr. Sonu Batham, Dr. Sonal Agrawal, Dr. Anjum, Dr. Sheetal Patel. So I hope all of you are here, or maybe you can just put on your video so that I can make out who all are here. I can see Dr. Sunita, who is not a part of the panel discussion. But yes, Dr. Padma, I could see Dr. Padma. Can you just help me in identifying the panelist here?
Madam, Dr. Neha was there, Ayushi was there.
Yeah, Anjum is there.
Dr. Anjum is there.
Anjum and Kalpana. I can see.
Dr. Sonu Batham is there, ma'am.
Yes, Dr. Sonu Batham. Welcome. So welcome. I think only Dr. Neha is missing.
And Dr. Sonal is missing.
Yeah, Dr. Sonal and Dr. Neha. So I think we can just carry forward the questions, whatever we do have, as you have already heard about the physiology of thyroid hormone synthesis, etc. I'm not going to talk about the theoretical aspects, but what we are talking about, hypothyroidism, which is mostly clinical hypothyroidism. And in our practice, what we are concerned much is the subclinical hypothyroidism, because as you all know, that subclinical hypothyroidism is very, very, prone for getting converted or progressing to clinical hypothyroidism. And of course, the effects are the same, whether it is subclinical or clinical hypothyroidism. So without much ado, I would straightway go to the case scenarios. And because Dr. Neha is not here, we can go ahead with the next panelist. We have this 23-year-old primary gravida whose BMI is 21 for antenatal registration. She comes to you at 8 weeks. You do her routine ANC profile, that is fine, except TSH 6.5 international units and T3 1.12, T4 6.6. So what is your diagnosis, clinical diagnosis here? How do you interpret this report as such? May I know who is taking up the questions? I think Dr. Aditi can take up this. Anybody? It can be extempored. We can start from Dr. Anjum. Dr. All of you, can you please unmute yourself? Yeah. Yes. All of you, please unmute yourself. Dr. Ayushi, you can unmute. Anybody can take up. What is your clinical diagnosis here? What is your diagnosis from this report?
Ma'am, she has a normal BMI. The TSH is raised. T3, T4 looks normal. As of now, I think I will also ask for a free T4.
The TSH is raised, you said.
Yes.
So what are the normal range, reference range for T3, T4 and TSH?
Yes, the normal reference range for TSH is in the first trimester, it is 0.1 to 2.5. In the second trimester, 0.2 to 2.5. And third trimester, it is 0.3. Second trimester, it is 0.2 to 3. And third trimester, it is 0.3 to 3.
Yeah. So very, very clear. So you mean to say that this is TSH is raised.
Yes.
Now, what is to just to make it very clear that at no point of time the TSH be more than 3. That we have to be very clear, right? So anytime it is more than 3, it is abnormal.
Yes.
What is your diagnosis here? That is what once again my question remains here.
This looks like a case of subclinical hypothyroidism.
Now I want you to justify why you call it as subclinical.
Because in subclinical hypothyroidism, the TSH is raised. But usually we look at the free T4, but here even T4, T3, they look to be under normal range.
Yes, so the levels of the peripheral hormones are within normal range for that particular laboratory, and only the TSH levels are raised. Okay, so this is what is called as subclinical hypothyroidism. Now, can you let me know what is the prevalence like and why are we worried about it?
Subclinical hypothyroidism, actually, if you look at the general prevalence of thyroid disorders, among that, almost 70% of cases are due to subclinical hypothyroidism.
So what is the incidence of hypothyroidism? I will ask. What is the incidence of hypothyroidism? First, we will talk about, and then we go to the subclinical hypothyroidism.
Incidence of hypothyroidism, if you look at a global average, it's around 2 to 4%, whereas in India, it can be as high as 11 to 16. Among that, the overt hypothyroidism constitute a very less number. On a global estimate, it's around 0.1 to 0.4, and remaining 70% cases are due to subclinical hypothyroidism.
Yes, so
In
on
India,
an average, the incidence of subclinical hypothyroidism is 3 to 10%. As you rightly said, in India, it is much higher, 11 to 16% almost. So why are we worried about subclinical hypothyroidism? I think we can have Dr. Sonu Batham speaking on this.
Yes, ma'am.
Why are we worried about subclinical hypothyroidism?
Ma'am, subclinical hypothyroidism usually does not cause any side effect over pregnant woman or fetus. It should be only treated if the TSS is more than 10, as the guideline says. But in the fear of
What are we doing? I think we can pass on this question to Dr. Kalpana, and we can go ahead with Dr. Padma Shukla. Do we have the answer? Yes?
Yes, madam.
Yes, Dr. Neha.
Good
I can
evening,
see
madam.
Dr. Neha.
Good evening, ma'am.
Good evening.
Oh.
Please take up. Anybody can take up.
Ma'am, may I?
Should I repeat? Yeah, please.
Yeah.
Anybody.
Ma'am, risk of hypothyroidism in pregnancy affects mother as well as fetus.
Yes,
All the
perfect. That
important,
is what the message very, very clear we want to give from this forum, that it is a myth. that subclinical hypothyroidism doesn't affect the mother or the fetus. It has to be very, very clear that yes, it is very likely to progress to overt hypothyroidism. And even if it is subclinical hypothyroidism, it has its adverse effects on the fetus as well as the mother. Okay, very good. Go ahead, please.
Ma'am, all the important high risk topics of associated with obstetrics, which we read in our textbook, is all associated with it, like anemia, even PIH,
Yes.
GDM, and PPH. These all are associated. Abruption. These all are associated with hypothyroidism.
Yes.
And if we look for the baby or the fetus part, abortion, the risk of preterm, IUGR, all are there. And
Yes.
with the natural delivery, it also
Yes.
affects the fetus also. So we keep on watch on the fetus also. That is our motto for targeting or neonatal screening. So it affects both. So we need continuous watch on the thyroid status of
Yes.
the mother very
Yeah.
frequently,
So,
as 4
Dr.
to 6
Ayushi,
weeks.
yes, very nicely discussed, Dr. Sheetal. So, Dr. Ayushi, Dr. Sheetal has talked about the effects on the mother, the adverse effects on the mother. What adverse effects on the fetus are observed if we leave this as untreated?
Good evening, all the respected seniors. I am highly blessed to be a part of this panel discussion and wishing you all a very happy Diwali. So, the adverse outcomes of subclinical hypothyroidism on pregnancy, as ma'am has already talked about the maternal complications, then the fetal complications can be the neurocognitive impairment can occur in the baby, the IQ level of the baby, the reading capacity of the baby. It can be affected in the long term period. Then developmental abnormalities, a milestone lag can be present. And in neonate hyperbilirubinemia, respiratory distress, more NICU admissions can occur in the baby.
Yes, yes, very good. In fact, I would
Even
say
there could
rather
be
right from beginning. Yes, Dr. Padma. Yes.
there could be even still birth even if
Yes.
there is TPO antibodies positive.
Yes, yes. So right from early pregnancy, even the recurrent miscarriages, the preterm deliveries, the as you have rightly said, yes, stillbirth, unexperienced stillbirth, as you have it in cases of hyperglycemia, you may have it for thyroid disorders as well. And then, of course, when you are talking about the neurodevelopmental abnormalities, the cognitive the behavior may be at a fault for the baby, it may be cretinism, autism. It can be anything. But yes, as somebody, as Dr. Aisha has pointed out, the prolonged physiological jaundice or hyperbilirubinemia, it can be even pathological hyperbilirubinemia. You have to keep a watch on the during the neonatal period. So, what are the risk factors for having this hypothyroidism? Can somebody talk about this? What are the risk factors? Which women have the risk factors? Which women are usually likely to develop hypothyroidism?
Ma'am, there is thyroid, iodine deficient areas which are where the patients are prone for the hypothyroidism.
Yes,
Second
there are
thing, if there
certain
is a
areas which
family
are
history,
endemic. Yes.
yeah, endemic areas.
Mm-hmm.
And if there is a family history,
Yes.
then also if patient has been treated for hyperthyroidism with the lithium or if patient has taken, she can go in hypo as well. If there is a
Mm-hmm.
Graves disease, then also there could be,
Mm-hmm.
or if there is TPO antibody positive, then also patient is having
Yes.
hypothyroidism.
And if she has undergone surgical removal,
Yes,
right?
yes, ma'am.
Thyroidectomy also.
Surgical.
Definitely. So, it can be some sort of radiation. If the thyroid is destroyed by whether it is by medicine, whether it is by surgery, whether it is by radiation. So,
Radiation.
any type of destruction of the thyroid gland or the tissue may lead to the decreased hormone production. And definitely, a woman who is obese, morbidly obese with a higher BMI, she's also, I mean, you have to keep it in mind that she may have hypothyroidism. So, I mean, what are the levels that we have already talked about? But is the new, I mean, screening should, are you all doing the screening as a routine or
Yes,
universal
ma'am.
screening? Yes. Or
Yes.
is it
Yes, ma'am.
mandatory? Is it
Yes,
mandatory?
ma'am.
Yes, it is mandatory, ma'am.
Yeah, so
Subclinical
It
hypothyroidism,
is
both
mandatory,
number.
ma'am.
yes, so Dr. Neha, in fact, for a clinician to avoid all these complications, to avoid the adverse maternal as well as perinatal outcome, we should do the screening, though by guidelines it is not mandatory. Only the Indian Thyroid Association says that it is mandatory, but Foxy ICOG still they have yet to come with the guidelines saying that universal screening is mandatory. Okay, so when it should be started, what is the proper way, how it should be done? So that's the reason all these questions remain unanswered. So whether Dr. Vidya has very nicely depicted upon the, what is total free T3, T4. So Dr. Padma, would you like to talk about this total and free T3, T4 and how it differs from each other? What is the importance?
Ma'am, total T3, T4 contains both thyroid, which is T3, T4, which is bound to the protein. And when we talk about the free T3, T4, it contains only the T3, T4, which is in the available in the blood circulation in the free form. So when we measure total T3, T4, it contains both. And total T3, T4 level can be affected by the level of proteins as well. For
Perfect.
binding protein, if they are less, then
Yeah.
the level can be affected, but free T3, T4 level won't be affected by the availability of
Yes.
protein.
So don't just get carried away by the laboratory report. Give importance to the report, whether it is total or free.
Yes,
As you have rightly mentioned, if it is free, that means it is not bound to the proteins. So the whether the reference range is for total or free, otherwise it will differ. And of course, as you have rightly said, that yes, hypoproteinemia can make a difference. Now, how do you what is maternal hypothyroxanemia? Can somebody comment on this? Dr. Kalpana,
Yes, ma'am.
what is maternal hypothyroxanemia?
Maternal hypothyroxemia means when levels of free T4 are low and
Uh-huh.
levels of TSH, serum TSH is normal, then it is known as maternal hypothyroxemia. It is
Yes,
a common condition in pregnancy, but
it's a common
fortunately,
finding. Yes, common
common
association. It's a,
common
yeah.
finding. Fortunately, it is not having that much bad impact on the fetus and mother. That's why we start screening with the serum TSH only, and if
Yes.
it is increased,
Yes.
then we go for free T3, T4 levels.
Yes.
for
So
screening.
somebody was talking about, Dr. Sonal, this is a question for you. Do we have Dr. Sonal? No, I think. So,
No, ma'am.
yeah, so we can have Dr. Neha and Anju once
Yes, ma'am.
again bring up this question. So,
Yes.
Dr. Neha, see, we have been, the guidelines say that if the TSH is more than 10, then only you should start with the treatment, right? But during pregnancy, I'm sure what is our practical experience, what is our practical practice, I would say, as a routine, that anytime the TSH is more than 3, we start with the levothyroxine. The dose may vary. So, because we all know that, at some point of time, it's going to progress to overt hypothyroidism. So if suppose some patient has less than 10 TSH, suppose 2.5 to 4, that is the range. Then how do you decide whether this lady needs actual treatment or no? In other
No.
words, I would ask you whether you want to do TPO antibody for this and what is TPO antibody? Neha, for you.
Ma'am, I'll for anti-DPO test, I'll go according to history.
Yeah,
If
what
she
is
has a
TPO?
history,
For the house, we can say what is TPO antibody? It's a thyroxine
Anti-thyroid
peroxidase.
peroxidase
Thyroid
antibody.
peroxidase
Peroxidase
antibody.
antibody.
Yeah,
Yeah, ma'am.
it is a normal thyroid peroxidase is a normal enzyme which is required for synthesis of thyroid hormones. And whenever you have autoimmune, that is the the body produces antibodies to its own organ or tissue. So whenever the body produces antibodies against its own thyroid tissue, that is thyroid antibodies or TPO antibodies. Okay. Now you can tell me that whenever you have this TSH levels between 2.5 to 4, just elevated than normal, then whether you would like to go for TPO antibody, and how would you interpret the result? Anybody
Yes,
can.
ma'am, I would like to
TSH.
Yes, yes.
TPO antibody.
Mm-hmm.
And if TPO antibodies are raised, then definitely I would like to start levothyroxine for the patient.
Mm-hmm. Suppose the TPO antibody is not raised and the TSH levels are between 2.5 to 4. What is your opinion?
Ma'am, if it is not raised, then I'll, along with the history, if there is any history of abortion, early trimester abortions
Perfect.
are there, then I will go for it.
Perfect. So if it is between 2.25 to 4, you do TPO antibody. If it is raised, that is positive, then you treat. If it is negative, then there is no need for treatment. You can just keep a watch whether it is progressing to the overt hypothyroidism. Suppose this lady has everything normal, hormonal assay, you do T3, T4, TSH normal, but still she has TPO antibody positive. What will you do?
If
Ma'am,
she's euthyroid, then she will not require any treatment right now. But we need to keep
She
a
has
watch.
RPL, recurrent pregnancy loss.
If she is a recurrent pregnancy loss, but she
Mm-hmm.
is euthyroid, only the
Yes.
TPO antibodies are elevated, I would like to keep a watch on the thyroid function test. I would
Mm-hmm.
like to repeat them every 4 weeks, particularly in the first up to 20 weeks, because this is the period during which the euthyroid TPO can progress to hypothyroid.
Mm-hmm.
And in case any point of the time we see elevated TSH, then this patient needs treatment with levothyroxine.
Yes. Any difference of opinion here?
yes, ma'am. Yes,
Yes,
ma'am.
please.
Ma'am, here according to our 2022 Foxy guideline itself, they said if there is history of pregnancy loss and we have a normal free, TSH and T3 values, but we are having positive of TPO antibodies, then we should start with levothyroxine. But ma'am, RCOG guidelines that is totally different on this, and it is like according to Dr. Anjum what she has
Yes. Yes.
that we
Even
should not
American
start
Thyroid Association states that
levothyroxine.
only the
Uh,
euthyroid with TPO
Only with
positive.
anti-TPO antibodies positive and with euthyroid status. So it
Yes.
is a dubious type of
Yes. So
situation.
what optimally, how we should take it as a practical message, that if she is having RPL and if she is euthyroid but TPO antibody positive, so the moment she plans for pregnancy, that is the best time when again you evaluate her, and even if it is at borderline, then you start her with levothyroxine. Definitely, at any point of time during pregnancy, the TSH level should not exceed 3. That we have to keep
Ma'am,
in mind. So
how will
both
we
the guidelines.
decide
Yes,
the
yes,
doses in this case?
yes.
Ma'am, if TSH is normal and TP positive, how how will we decide the doses of LT4?
Yes, we are coming to that. We will be having some discussion on that. So TPO antibodies we have already discussed, and I'm happy that all of you have contributed to this discussion. Even if it is, you can see this here. Even if euthyroid, if she is TPO antibody positive, then the woman, if she has RPL, then definitely we have to consider her for treatment. That is what the guideline says. Of course, it's a FOXY guideline, our parent organization guideline. So whatever practically we need to practice here, we have to follow the guidelines, though we can make use of both the guidelines and optimize our practice. How do you plan and monitor this treatment, and what is the target range for TSH? Do we have Dr. Sheetal Patel here?
Yes, ma'am. As
Please,
we have
please.
already discussed this question, but
Yes.
in reverse way, the
Yeah.
target range for the TSH as already mentioned for the different trimesters, we have 2.5 and 3 and 3 respectively for the upper range.
Yeah.
So this is our target. And once the patient come to us, first we will go with TSH and free T3 values. About TPO antibody disease, again, ma'am, we needs your opinion. RCOG guidelines does not say that we should go with TPO antibody for every cases, but our parent organization says that we should go with TPO antibodies at every first visit with every case. So according to the TPO antibodies, TSH and
So
FT4
Foxy
values.
guidelines do not advise us for TPO antibodies for every patient.
Ma'am, in 2022, they have mentioned that at first visit we should go with this TSH free T.
TSH, yes.
And
It gives
ma'am,
you
along
a
with this,
screening. Yes,
TSH,
there's
T4,
a
and
screening for
TPO antibodies.
hypothyroidism. But if the TSH is elevated, then you go for TPO antibodies. That is what we are discussing. That if the TSH is between 2.5 to 4,
So
then we
then,
go for TPO antibodies. Not for every case, right? So that is what very, very clear. So how do you go for the monitoring of the dosage?
monitoring we will do every 4 to 6 weeks.
Yes.
Ma'am, till 28th week, and once at 28th week is must. We should get it done. And the doses will be accordingly, like if it is more than 10, it is means severe type of subclinical hypothyroidism, then without looking for anti-TPO antibodies, we will
If
start
the
with
TSH is more than 10, you label it as overt
Yes, it is overt
but ma'am,
hypothyroid.
they have mentioned if it is more than 10, and even when the free T34 values are normal, and it is subclinical hypothyroidism with very severe range,
Yeah,
and
agreed.
then we have to start with 1.6 microgram per kg body weight per day.
Yes.
Between 4 to 10, we have two opinion, means we have two ways. One with TPO antibody positive. If it is positive, we are matlab it is recommended to start with levothyroxine. But if it is negative, we can consider to give. And with 2.5 to 3 means it is very nearby to our range. So as we have already discussed, according to the history of recurrent pregnancy loss or TPO antibody, we will decide to start with the dose. So in cases there the TSH values are normal, 25 to 50 microgram per day has been mentioned according to RCOG, ma'am.
Yes, perfect. But then what Dr. Sonu has asked us, how do you monitor? So you just keep on monitoring the TSH, see that it doesn't go. I mean, we are thinking that we have to start and see that the TSH at no point of time goes above 3, right? So it can go right up to at least maybe 2.5 to 3. That is what we are considering. But if it goes below 0.1, then definitely we have to think of decreasing the dosage, right? So this is what the TSH levels like. If at all we are giving her 50 milligram of levothyroxine, TSH goes below 0.1, then you have to of course reduce the dosage to 25. So for all the dosages, whatever the maybe the ongoing dosage, if the TSH goes below 0.1, you have to come down by 25. That is what the recommendation is. Okay.
And one thing is left, if our patient is with overt hypothyroidism and she's already taking hypothyroid drug, then we have to increase the dose by 30%. And that 30% we made by two ways. Either we can double the dose on 2 days for a week, means on Saturday, Sunday we can double the dose, or we can add either 25 either 50 microgram per day or 100 microgram per day according to what she was taking previously. If she
I
was
think 25 and
because
50.
nowadays we have all the formulations, including 12, 25,
33.
37, and 88 and everything. So I think no need to go for, these women, they are already non-compliant. And how it is very, very difficult for them to remember those days where she has to take those 2 tablets extra. So
Yes.
better that you optimize her dosages and ask her to take it daily. I think that should be the best for her.
I
So
think if
any
she's
special
already taking
precautions?
a
Yes.
dose of less than 100, maybe we can increase by 25.
Yeah.
And if she's taking a dose of more than 100, increase it by 50 microgram per day.
Yeah, that is
That will
what,
be
in fact, what is we have been talking about, that we have to just, I think every time if the TSH is exceeding the value, just increase it by 25. That is what the message. And of course, you are monitoring it every 4 to 6
yes.
weekly. So not to
Yes,
go
ma'am.
into any controversies. So
Yes, ma'am.
anybody can just enumerate, I mean, how do you tell your patient in a proper way? How should she take? Because this is very, very practical, very important message for the patient. Anybody can take up.
Ma'am,
Take it on a
Dr.
empty
IC,
stomach in the morning
yeah, Anjum,
in a
yeah.
single dose.
Mm-hmm.
And you should not take anything by orally at least for a 30 minutes after taking the medications.
Mm-hmm.
In case she vomits the tablet within 30 minutes, she may have to repeat the dose.
Yes.
Second thing, if there's a lot of hyperemesis during pregnancy, it has also been advocated that she can take it in divided doses at a time when her vomiting periods are quiescent through the day. Whenever there are periods when she is vomiting less, she can take the dose at that time in cases of severe hyperemesis.
Yes. So it is empty
Even
stomach, basically. Empty stomach. That is what is very, very important. And she should not consume anything orally at least for half an hour to 1 hour after taking the tablets. I think that should suffice. Definitely, as you said, early morning, she definitely has means morning sickness. And if she's not comfortable enough, she can take it in the afternoon when at least 4 to 6 hours she is not taken anything.
Yes.
So that can also happen. Something is better than nothing. But what we have to recommend ideally is morning hours, empty stomach, and she should not consume anything for at least 1 hour after. So she should take it with a full glass of water. Correct? Because
Yes.
most of this, yeah, because it gets dispersed, disintegrated, and then maybe she will face all these problems of hyperacidity and all this. And definitely she should not take it along with her other medications, iron, calcium, antacids, to antacids. Some people, I'm telling you this because some people say if you're getting acidity, you take antacids and then you take the tablet. So that is not the way because antacids decrease the absorption of these drugs.
Ma'am,
Anyone
it is
can.
also recommended
Yes.
that patient can take in the night as well after taking her meal, and 3 hours after her meal, she
Yes,
can take
that's yes,
a
correct.
tablet.
That is what exactly we discussed, that even any time of the day when she is comfortable and has not consumed anything over the last 3 to 4 hours. So as we are talking about afternoon, evening, or late night, also she can
Yes.
take it. Okay.
Ma'am,
So
one more point.
what? Yes.
We should go with this particular same brand.
Yes.
Brand of the drug should not be
Yes,
changed.
that is what we are coming to. What precautions for the strength, the brand, and of course exposure to sunlight, etc. Anything else, Dr. Ayushi? Do you want to talk about this?
Ma'am, the same brand of the tablet should be used. Patients should be counseled that and encouraged about the same. The packaging or the tablet should be placed in a moisture less area, like in at the room temperature and
Yeah.
away from the sunlight and heat.
And that is why those amber color bottle, right?
Yes.
Yes. Huh. Now, I would ask Dr. Padma,
Yes,
what
ma'am.
are the drugs that interfere with this levothyroxine, and how do you, what precautions do you advise the patients that which are these drugs and whether you really need to increase the dosage of levothyroxine if they're taking these drugs?
Patient should not take any, as you told, that the patient should not take levothyroxine along with the other drugs. That is important.
So which
And
drugs? Which drugs specifically? Iron, calcium, antacids, we have already
yeah,
talked. But there are some patients,
no,
they have some other elements.
yes, ma'am. So if patient is having amiodarone, is taking amiodarone or beta blockers, and then she should not take along with that. And if patient is on any anticoagulant, that
She needs
also
to take
should
those
not.
medications, no? Because
She
she is
needs, yeah.
suffering from
So it
those
should not be
ailments.
taken. So definitely we have to increase the dose accordingly if the patient is taking all these drugs like anticonvulsants or warfarin if she is taking.
Insulin also.
Yes,
It
ma'am.
also
Insulin
increases the
also. Yeah,
insulin
ma'am.
requirements, okay?
Insulin also.
So,
Yeah.
so definitely we have to
Insulin
be
also
careful
and
about.
anticonvulsants.
Yes, yes. Now, I think we are warmed up with the case now. We have this second case, Dr. Ayushi, for you. We start with you. We have this bad obstetric history case. This lady has BMI of 25, higher side, previous 3 abortions. And her TSH is 38. T3 is zero point 0.4, T4 is 1.2. All other investigations, they are within normal limit. And she comes to you for preconception counseling. Preconception counseling. How will you proceed? What is her diagnosis at this stage? What medication you will start? What advice you will give? And when should she conceive?
Yes, ma'am. Now, considering that all her analysis and her husband analysis are within normal range, now her BMI is 25. That means she is overweight and with the bad obstetric history, previous recurrent abortions are there, and TSH is 38. So she is definitely a case of overt hypothyroidism, and she needs to be encouraged about the compliance of the treatment, and adequate replacement with the drug needs to be given. That is, levothyroxine therapy needs to be started in her. Uh, if she was taking suppose 100 microgram, then her dosage needs to be increased up to 25
What
to 30.
advice about her BMI?
Ma'am, she needs to be counseled that her weight reduction needs to be done, because the leptin that is secreted in the body, it in a way
Yes.
it increases the TSH level. So
For
the
her
weight.
previous 3 abortions, what investigations you would like to go for?
Ma'am, all the blood work needs to be done, but since the investigations are already in the normal range, so we are
Yes.
treating her as
But
overt
apart from routine, I'm sure you will say, I mean, what we get from here is all routine investigations. Apart from this, any other investigation you want to do? Previous 3 abortions or any RPL, how we, evaluate?
Ma'am,
Probably
the complete.
profile, karyotype, husband, wife, definitely, right?
Yes, ma'am.
Okay. Now, how coming to the management of this, because we don't have to focus on hypothyroidism per se, but we have to evaluate the patient as a whole, right?
Ma'am, even I would like to ask about the abortion, means whether they have happened in first trimester
First
or they are
trimester,
second
yes.
trimester
Previous
abortion.
3, first
Yeah,
trimester abortion.
trimester abortion.
To be very precise, yeah, first
Any
trimester.
history of diabetes should also be excluded in the family as well.
Yes, yes,
Because
yes.
her BMI is more.
Yes. And this routine investigation includes obesity, which
And
is
APLA should
negative.
be done.
Which
Yeah.
is negative, yes.
Yes, ma'am.
Okay. So go ahead, please. What counseling you want to do?
Ma'am,
TSH is 38.
I would like to ask her, advise her that she should, at least she should not conceive till
She becomes
her
euthyroid.
serum TSH
Yeah,
level
she
is
becomes euthyroid. Yes.
2.5 years. She becomes euthyroid.
Mm-hmm.
And I will advise her to take the levothyroxine, as her TSH level is 38. So we can give 50 or
At least 50.
50
Start
microgram.
with 50.
Start with 50 microgram, and we can repeat her TSH level after 4 to 6 weeks, four
Yes.
weeks.
Yes.
And if it is high, then we can increase the dose till the patient becomes euthyroid.
Yes.
And as she is having already 3 abortions, we can counsel her that once she will become euthyroid, we'll do the TPO antibody as well in this patient also.
Yes.
That whether her TPO antibody is positive or negative, so that we can counsel her regarding that about the TPO antibody as well. And we can assure the patient that if TPO antibody is negative, she is having only TSH level is high, then we can assure that if she will become euthyroid, then there are less chances of abortion
Yes,
next time.
perfect, perfect. So we have already discussed about starting this, and then of course she has to maintain this. Before pregnancy, she should become euthyroid, and she has to get evaluated herself every 4 weekly, and she should maintain the TSH less than 2.5. That we have to make sure during first trimester,
Yes.
less than 3 during second and third trimester. That we have to ensure. Now, what are the implications, on this pregnancy? Suppose this lady has very high TSH, and this we have already discussed. This is, I think, just a revision once again, that she can have all these complications. We have already discussed if at all she conceives, then she can have all these problems during pregnancy. So better that she gets euthyroid to avoid all these maternal and fetal complications. Now, suppose we have talked about that the TSH has to be below 2.5 during first trimester, and below 3 during second and third trimester. Your patient reaches term and then she delivers uneventfully. How should you now monitor her TSH, and what dosage of levothyroxine she should continue?
He should continue the dosage of euthyroxine, keeping in mind her TSH level should be below 2.5. So she has to be monitored for the thyroid function test every 4 to 6 weeks.
Yes.
Or if you are changing the dose, then after any change in the dose, you have to repeat the thyroid function test at 4 weeks to see
Yes.
and adjust accordingly, depending upon the TSH level. If they are well controlled, continue with the same dose. And if they are high, then you have to titrate the doses so that we can achieve the desired TSH levels.
Okay, so her TSH level, suppose, she has been managed perfect, and after puerperium, usually we ask her to repeat it after 6 weeks. So
Yes.
if her TSH is 3, suppose, would you
Yes.
advise her to continue with the treatment, or would you advise her to stop the treatment?
Because her thyroid was not under control before conception, we cannot stop immediately.
Correct.
We have to ask her to go back to the pre-conception.
Pre-pregnancy.
Yes, pre-pregnancy thyroid medications. If
Perfect.
at all it was under control, you could have stopped it and
Yes.
then seen the levels again at 4 to 6 weeks and then decided regarding further management.
Yes. So because our patient had her TSH level as 38, we will not stop. In fact, we will continue it for at least 6 months during the period where the woman is doing exclusive breastfeeding for her baby. So
Yes.
preferably we continue it till 6 months and we evaluate every 4 to 6 weeks. Now, for this baby, is the neonatal screening mandatory? Dr. Sheetal,
Yes.
have your comments, and if yes, why? And when?
Um, yes, ma'am. Neonatal screening is mandatory, and within 48 to 72 hours, we should get it done.
Mhm.
Already discussed with the neonatal complication that occurs with hypothyroidism. The mother hypothyroidism leads to fetal, so we can diagnose it earlier, and the drug can be started.
Correct. Now, this is a question for Dr. Padma. If this lady has, a patient who comes to you with her TSH report of 100, would you advise her termination of pregnancy? If yes, why? If no, why? And how would
No,
you counsel
uh,
the patient?
no, ma'am. Actually, previously it was recommendation that if the TSH is so high, so we should terminate the pregnancy. But now the recommendation are that we should continue the pregnancy and we should start the levothyroxine for the patients.
But still, I would ask
We need to
I would
counsel
ask
the
for some
mother regarding
clarification.
all the
TSH is 100.
complications involved.
Anybody else
Yes,
can
ma'am,
add.
but we have to counsel about the
Counseling and
Yes,
complications.
informed
that is
It
what
is
decision.
yes,
yeah.
perfect.
We
Your
have to
answer
counsel
is
for that.
correct, but incomplete. So
Yes,
why?
ma'am.
Because we
Yes,
want to
ma'am.
protect ourselves,
Yes.
right?
Yes, ma'am. So
Yes.
we have to tell the complications
Yeah.
which can occur in the fetus.
Perfect. In fact, other way around, I would say that you should never tell the patient to undergo termination. You
Yes,
should
ma'am.
just
Should
tell
always
what
be
the
informed
pros
parent.
and cons of this reports are, what can be the adverse effects on the mother and the baby, what can be the benefits of continuation of this pregnancy. But suppose sometimes you have, a long-standing infertile lady who
Yes, ma'am.
conceives with treatment and she gets her TSH so high. So all of a sudden you cannot just tell her that, you have to undergo termination of pregnancy. You with guided explanation and evidence, you can tell her that these are the problems if you continue the pregnancy. But do not recommend termination of pregnancy at any point of time. If the patient is willing with informed consent, make the patient write the informed consent and sign it, and then you continue it. That is what the ideal counseling and treatment is. So the second case is also well discussed. Now, I think hyperthyroidism, we have had the talk, but just to revise, only one case we go for. Is that okay, Dr. Padma?
Yes, ma'am.
So anybody can take up this. Once again, we start from Dr. I think Kalpana. Dr. Kalpana is missing in the discussion, and maybe I cannot see her. Do we have Dr. Kalpana here?
Yes, madam.
Yes.
Since
Yes, yes. Please.
TSH
So
is
I
low.
read the case for you. We have
Yes.
this 21-year old lady who is stillborn, primigravida, 8 weeks pregnancy. TSH is less than 0.01. T3, T3.5, and T420. All other investigations are within normal limit. We take it as it's a routine ANC workup, which we do it at the first visit. Clinical parameters suggestive of hyperthyroidism, right? There are some features which are suggestive of hyperthyroidism. We'll come to the discussion why I mentioned this and how will you treat this lady. So she has hyperthyroidism, that is but obvious. I can see Dr. Aditi also here, but I think Aditi has been quiet for some
Ma'am,
time.
I'm not the part of the panel basically. So
Is it? Okay. So, yeah. So we just thank you for being here as a secretary of Ratlam. And Aditi, thank you so much for, being a part of this program till the end.
you,
We
ma'am.
just,
My pleasure.
thank you so much. So we just ask any of the panelists, I think I'd be happy if anybody can take up this case of
Yes, madam.
hyperthyroidism.
We will start with the propyl thiouracil.
Mhm.
300 to 450 milligram in divided doses.
Yes, yes.
Till 16 weeks of pregnancy,
Okay,
and then
okay.
we switch over to
Dr. Yeah,
metformin.
Kalpana. So I would just interrupt you here. I know that, but then just for the clarity of the house, 150 milligram 3 times a day, as you said, 450 milligram in divided doses. That is how we take it. Why do you select only propylthiouracil for this lady?
Because, madam, the effects on fetus congenital malformations are less. Malformations are there with propyl thiouracil also, but the severity of malformations is less in compared to methimazole or carbimazole.
Okay.
That's
Anybody
why.
else? Does it cross the placental barrier?
Yes, madam. It
So
crosses the
all these
placental
drugs cross
barrier.
the placental
All the
barrier, but the
process.
severity of the abnormalities are less with propylthiouracil. It's the lesser devil. That's what we can say. Okay, so up to 16 weeks you continue with propylthiouracil, and then you can change over to methimazole or carbimazole. How do you choose the drugs and dosage, and are these drugs safe during lactation also?
Yes, ma'am. During lactation also, during lactation we can switch over to methimazole. Both drugs
She's
are
already, no? She's already on methimazole or carbimazole during pregnancy.
So
Okay.
we can continue with the methimazole in during lactation because it is less hepatotoxic in comparison to propylthiouracil.
Yes, propylthiouracil has been a very notorious drug, and patients have landed up into liver failures and liver transplantation also. So even though the chances for congenital malformation are less, we have to be very, very cautious about its hepatotoxicity. And only for few months of organogenesis we can start with these drugs. But we have to be very, very vigilant on our monitoring. So fetal monitoring all throughout the pregnancy, that we have to do this. So Dr. Vidya has very nicely discussed, but I still ask you. I have said there are certain features of clinical hyperthyroidism. So how do you differentiate the clinical hyperthyroidism during pregnancy from the Graves' disease?
Clinical hyperthyroidism and Graves, they may both present with the symptoms, no doubt. But usually the goiter, the ophthalmopathy, etc., are more common with Graves.
Graves,
Same
yeah.
thing with this is transient
The
phase.
history itself, Dr. Anjum, in the
Yes,
history.
take a history, proper history, if suggestive of any problems prior to the pregnancy, because the gestational hypothyroidism is a transient phase, whereas the Graves' disease, it improves as the pregnancy progresses. Gestational hypothyroidism usually settles by about 14 to 16 or 18 weeks, and usually doesn't require any treatment. Here, no doubt, the FT3, FT4 may be elevated, but in Graves' disease, there is elevation of both FT3 and FT4. We see plus presence of thyroid receptor antibodies.
Yes.
In the Graves.
Naturally, you may have some sort of, family history of some of the other autoimmune disorders.
Yes.
Usually, they have some of the other, disease, autoimmune disease. And of course, the here in Graves disease, the levels of thyroid hormones are markedly
Much
elevated,
higher
where it
compared
is
to
not so.
gestation.
And of course, no antibodies will be seen, whatever, whatever seriousness of the hyperthyroidism during pregnancy, of pregnancy may be there. So usually it is silent and it subsides on its own. Whereas, Graves disease definitely requires treatment. Somebody has said, even physiological hyperthyroidism during pregnancy has landed up into some surgical problems, some surgical treatment. But I don't think such rarity has been experienced. Definitely, Graves disease requires a very aggressive treatment. And Dr. Vidya also has shared one point which you have to keep it in mind, that during pregnancy you don't have to go for any aggressive treatment for this, because you have to keep the thyroid hormones on little higher side. These are all the drugs which can lead to hypothyroidism. They are very, very aggressive drugs, and you have to keep the thyroid hormones at a little higher side. The TSH should be little lower only, because the fetus can anytime go into hypothyroidism, and that is not affordable. So that is how you have to be, how for hyperglycemia also you have to make it, that during pregnancy the control should not be very stringent. It should not be euglycemia, tight euglycemia. Likewise, during pregnancy, even the thyroid hormone should not be very tightly controlled. In fact, it is good that they are little on the higher side. That is always good. Now we
Ma'am,
just come to, yeah, sure.
Patient with Graves disease, you can detect, diagnose them, but just seeing once you enter the ward, in the ward, you'll see the exophthalmos. And
Yes.
that is a very typical picture, and you can diagnose them in that way also.
Yes,
But
very rightly pointed out.
definitely with the TSH level and everything, TPO antibody, thyroid receptor antibody, we have to go for it. But the clinical diagnosis can also be made
Yes,
to some
definitely.
extent.
Dr. Anjum has talked about the ophthalmic manifestations. So
Yes,
the
ma'am.
ophthalmos, very classical of
Very
Graves
classical,
disease.
yeah.
Yes, yes. So these are the maternal and fetal complications you all have heard already, and this is the algorithm of management of this, thyroid hormones, when and how it should be done. We have been discussing it. Only message from this discussion, what we have to take home is universal screening is recommended by Indian Thyroid Association and recently by FOXY as well. TPO antibodies should not be tested routinely only in cases of borderline hypothyroidism and cases of bad obstetric stress, or what we label it as RPL. Fetus is totally dependent on the maternal thyroxine up to 16 weeks of gestation, and therefore preconception screening is highly recommended for better fetal outcome before. Have to remember that at any point of time during any trimester, the TSH should not be more than 3. So that is how you diagnose for the subclinical hypothyroidism. It's always better to treat the subclinical hypothyroidism because the progression is quite, obvious. And once it progresses to overt hypothyroidism or even with subclinical hypothyroidism, the adverse effects of mother and fetus are there, and that's a very reason we have to manage the patient even if she has subclinical hypothyroidism. The routine practice is that even if the TSH is more than 3, we start with minimum doses of levothyroxine, that is 25 milligram. As I have already said, if the hormone levels are at a higher level, it does not bring about any problems or any adverse effects on the pregnancy. Failure to treat, in fact, can reduce the IQ level by 7. I think so we have to keep a very, very, delicate balance between the hypo and the hyper thyroidism to make your pregnancy a successful pregnancy with good outcome. So balance is not something you find; it's something you have to create. So be very vigilant and be very, very, very cautious about your pregnancy, whatever you're managing. You have to definitely keep a delicate balance to succeed as a very good obstetrician, I would say. And definitely you can sell through without any problems in your clinical practice and of course the litigations as well. With this, I complete
One more
our
thing,
panel
ma'am.
discussion. Yes, you can add whatever. I just thank all of you for having me here, and I thank especially all my wonderful panelists being so interactive and adding values to our discussion. Thank you so much. I just take this opportunity to convey my feelings to you that, as all of you know, I have been very active in FOXY and the academic body ICOG. I'm not a politician at all. The first doctor of the family, practicing high risk obstetrics since last 31 years, and with my highest success in my obstetric career. Now that I have come into FOXY, representing a common FOXian like all of you, and I wish to go ahead as Vice President FOXY with all your support. So I need your support and your votes for the upcoming elections, which I'll be facing in August 24th. Thank you so much.
All the best.
Definitely, madam. Thank you so much.
Thank you, ma'am. And all the best, madam, for your elections as well. Thank you so much, ma'am.
Thank you so much. The discussion, you can add your points if at all you have any suggestions, and I'll be here to.
Ma'am, one point I would like to add that a patient with overt hypothyroidism or patient with TPO antibody, I used to start tablet ecosprin as well to prevent the PIH, and IVR in such patients.
Yes, Dr. Padma, you have opened another Pandora box.
Yeah, ma'am, but
yes, that's what I'm. In fact, I
Yes,
appreciate because this was a discussion on thyroid dysfunction. We have restricted ourselves to saying that, Dr. Sheetal, she commented on this issue that if you have a hypothyroidism, maternal adverse effects and hypertensive disorders of pregnancy is one of it. Okay, so for that, when we talk about HDP justosis, maternal characteristics, maternal history, and all this, we calculate this as HDP justosis score. And if for hypothyroidism, the score is very high, that is 3. And if you have a total score of 3, then you start on low dose aspirin and high dose calcium vitamin D3. So hypothyroidism per se gives you a score of 3. That makes you very, very high risk, makes your patient very high risk. And definitely your suggestion is well taken. Yes, aspirin 75 milligram for average weight and 150 milligram for a patient weighing more than 70 kg. Thank you so much.
Thank you, ma'am. Thank you so much, ma'am. We learned a lot with this discussion as well.
My
Thank you, ma'am.
pleasure, and it's always learning together, and we continue our journey throughout. Hope to meet you soon and catch you personally also.
Thank you, ma'am.
So
Thank
much.
you
And
very much
Dr. Vidya, yes, Dr. Sunita.
From Ratlam Obstetric and Riva Society. Both of the societies are enlightened because of you people's efforts on this. Thank you,
Thank you
ma'am.
so much.
And we are with you, ma'am.
Thank you so much. Over to you, Dr. Aditi.
Thank you, ma'am. It was a wonderful, wonderful CME. And as your final slide said, that balance is not something that we have, but something we create. So it has been a very well balanced talk with all the eminent people being there. So though most of them have left, but I would like to thank first and foremost Sneha Bihar ma'am for giving me the opportunity to be a part of this CME. Then also I would like to thank Sahiti for being there, helping in getting it through. I would thank Rajendra Pardesi sir, Dr. Kavita Singh ma'am, Dr. Lakshmi Shrikhande ma'am, and Binu Kushwaha ma'am for being the part of this thing. I would like to thank my president, Dr. Sunita Vadvani ma'am, and my very senior ma'am, Dr. Dolly Mehra ma'am, guiding me, and Dr. Leela Joshi ma'am. And I would like to thank Dr. Padma Shukla ma'am for helping me throughout, and Dr. Rekha ma'am. And then I would like to thank all the panelists for being there. Dr. Anjum, Dr. Neha, Dr. Ayushi, Dr. Sonu, Dr. Padma again, and then Dr. Sheetal and Dr. Kalpana. And I would like to thank Vidya Tobi ma'am last but not the least for clearing so many doubts which I had in my brain. But it has been an all comprehensive talk, a very comprehensive talk, and I'm so glad that I was a part of it and stayed throughout. And ma'am, it was like a Bible. Her talk was like a Bible on thyroid, and it was a much needed thing which we most of us common practitioners need. And ma'am, we wholeheartedly support you on your endeavor for the future elections and would support you whenever we can. Thank you so much, ma'am.
Thank you very much, ma'am. And we would like to have many such